As I mentioned earlier when we were talking about lateral ankle sprain, the muscles along the lateral aspect of the leg are often injured. For many years, they were called the peroneus, longus, and brevis. They're currently now called the fibularis, longus, and brevis. So the names are used interchangeably, but accurately it would be the fibularis muscle group. They are often injured secondary to ankle sprain, but they can also have a strain of their own, not related to ankle sprain. So the fibularis root come down along the lateral aspect of the ankle. They have sheathed tendons that cross behind the malleolus. The fibularis brevis attaches to the fifth metatarsal, and the fibularis longus attaches around onto the bottom of the foot onto the first metatarsal. In observing for fibularis injury, we are looking for swelling or redness. In chronic cases, there may not be any swelling. There's probably won't be any redness, but you may notice that the tendon is not still crossing behind the malleolus, but may have subluxed so that the tendon comes up across the actual head of the fibula on its own, or the malleolus on its own. For the range of motion testing, specifically for fibularis group, we are going to have the client go through active motion, passive motion, and we'll do some resisted tests. So, Sammy, I'm going to have you start by actively inverting your foot. What we're looking for during active motion is pain or discomfort, and where it occurs during the motion and what the quality of it is, if you will. And then active eversion, and then come back to neutral and active plantar flexion and active dorsiflexion. So we'll make note of any pain or discomfort that the client feels, followed by passive motion. In a fibularis injury, we would expect passive motion to be relatively pain-free, except at the ends of range where stretching the injured muscle or tendon may cause some discomfort. So especially we'd be looking for discomfort as we take the client into passive inversion and we stretch this whole muscle tendon unit. Sometimes during passive eversion, there's some pinching or jamming of the tendon as it comes down across the malleolus that might also indicate a pain process. Passive plantar flexion would not be thought to be painful. We would not expect that. Passive dorsiflexion could be slightly painful because there's some bit of stretch on the peroneal or fibularis group as we do this motion. Following passive motion, we've made note of any pain or discomfort, where it's located, at what point in the motion it occurs. We'll do some resisted tests because this is what really challenges the muscle tendon unit of the fibularis group. So with the foot in neutral, she's going to evert the foot. It's just sort of a moderate level contraction. We hold that for a few seconds just to see if it generates any pain symptoms and relax. If that generates pain, that would be a positive test for some issue going somewhere along the fibularis muscle belly or tendon. And the client may be able to pinpoint where the pain occurs, which is a good information for us to have as we get into our palpatory exam. For fibularis injuries, we would not expect the resisted inversion to be uncomfortable, but we're going to give that a shot anyway. Go ahead and try to push your foot in and relax. So if that was painful, we'd have to figure out where the pain is located and if there's some other accompanying injury that's creating that painful sensation, because resisted inversion of the foot should not engage the fibularis group at all. The palpatory exam now would be limited, hopefully, by the findings of our previous range of motion tests, active, passive, and resisted, and the client's information about where they feel the pain and at what point in the range of motion they feel the pain. So we would just basically palpate for the areas where pain was identified by the client, whether it's in the muscle belly. More often it's going to be in the tendon unit, and because the fibularis tendons are sheathed tendons, we would do the palpatory exam with them on a little bit of a stretch. so that we can create a firm surface to rub that sheath against the tendon with. I'm going to turn for the camera, so I use my opposite hand, but typically I'd be treating this side. So we're going to start just proximal to the lateral malleolus and just do some light transverse friction palpation to feel the tendons and for the client to report any pain or discomfort, especially that kind of pain or discomfort they're complaining of when they come to see us, all the way down to the 5th metatarsal here. So palpation along and behind. And this palpatory exam will inform our decision about whether to do deep transverse friction treatment for this condition or not. For doing deep transverse friction treatment for Fibularis group, again, we'll use the information that we have about where the pain is that the client's experiencing and focus our attention on that. We're looking for the most painful spots along the muscle belly or the tendon in order to do the friction work. So again, because this is a sheath tendon, we're going to have the muscle tendon on a little bit of a stretch, and the deep transverse friction work is done with flat fingers. You could use a braced finger like so, or double fingers, and it's a slow friction work back and forth across the tendon. The first application of deep transverse friction is about a minute, and we're trying to keep the discomfort level on about a 7 on a scale of 1 to 10. Typically, after a minute, the pain has diminished a bit. We could also be treating somewhere down here along just underneath the malleolus. Wherever the most painful spot is on the tendon unit is where we apply the deep transverse friction. Following the deep transverse friction work for the Fibularis group, we can do some isolytic contractions to help reset the muscles. Isolytic contractions, as you recall, are eccentric contractions with the client resisting the lengthening of those tissues. We're going to start with the tissues in the shortened position. So Sammy's going to evert her foot to shorten the Fibularis group. And then I'm going to invert her foot while she resists that motion. So that would be an eccentric contraction. We're loading the muscle, keeping it loaded even while it's lengthening. And we're going to start with mild resistance on Sammy's part. So Sammy, I'm going to start to pull you into inversion. Let me have it. Let me win, but make me work a little bit. Not quite so hard. A little easier. A little easier. Let it go. There you go. Like that. Okay, so we want her to completely resist all the way through this range of motion. If that's not uncomfortable, then we'll go back to eversion, and then with the second round, you're going to do a little bit more resistance, Sammy. Not quite so much, though. Hold it just like that. We want that to be a nice, smooth motion. If she has any kind of chattering or stop and start, we're going to add a couple more at that level of resistance. So once again, Sammy here, and so this is nice and smooth. She's able to control that nicely. We're just trying to re-engage this Fibularis group. So you'll do 2 or 3 rounds of isolytic contraction here. And just as a finishing touch, you could do some facilitated stretching for the same muscle group. You don't have to do all of these at the same time, but you can mix and match them as you see fit. A facilitated stretch, we start with the muscles lengthened as far as she can actively go in the pain-free range, and then she's going to try to do an isometric contraction, now contracting these muscles, and press out against my hand. That's an isometric contraction, getting ready for the muscle to lengthen even farther and relax, and then stretch by actively pulling into inversion. And she could do that. We could do that a couple of times with her.